All right, good morning, everybody. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine Serious Communicable Diseases Program, or SCDP, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. For those of you who tuned in previously, I clearly am not Dr. Gavin Harris, your usual host. My name is Jay Varkey. I'm an associate professor of infectious diseases at the Emory University School of Medicine, and I also serve as chief quality officer at Emory University Hospital, and I will be your host for today. Before we begin, please know that we'll be recording this session, and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for the Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. If there are any issues during the webinar, please send us an email or type it in the chat. If you'd like to ask a question during the session, please type it in the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we're able. If we do not get to all the questions, we'll post a recap addressing these topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of the session. The presenters and the planners of the session have no financial conflicts of interest with ineligible companies to disclose. In terms of our agenda, which is now on the screen, we're going to start with a Region 4 situation report. This will be followed by our case and didactic presentations with a moderated Q&A to follow. Now it's my honor to introduce our guests for today. First, I'd like to welcome back Dr. Liliana Sanchez-Gonzalez, medical epidemiologist with the Centers for Disease Control Dengue branch in San Juan, Puerto Rico. Dr. Sanchez-Gonzalez has extensive domestic and international field experience, having participated in the response to dengue, measles, and COVID-19. Currently, she leads and participates in several research and surveillance projects related to mosquito-borne diseases in Puerto Rico. Next, I'd like to welcome Dr. Jessica Fairley, my colleague who's also an associate professor of medicine in the Division of Infectious Diseases here at Emory. She also holds a secondary appointment in the Huber Department of Global Health and the Department of Epidemiology at the Rollins School of Public Health. Dr. Fairley is deeply involved in the GeoSentinel and Global Travel Epi Network tools as part of her role in the Emory Travel Well Center. And she has also been the director of the Atlanta Hansen's Disease Clinic since 2012. And lastly, I'd like to welcome back Dr. Sherry Drenzik, the state epidemiologist and chief science officer at the Georgia Department of Public Health. Dr. Drenzik has been integral to the Georgia Department of Health for many years and has been at DPH since 1999. She has served in various epidemiology leadership capacities, including leading the state's epidemiologic response to COVID-19. A veterinarian by training, she's also been assistant professor of epidemiology at the University of Georgia College of Veterinary Medicine. Welcome to you all. Now, to place this session in context, the Emory University SCDP, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, which is HHS Region 4. These sit reps are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. Here's the current HHS Region 4 special pathogen sit rep recorded earlier by Dr. Harris.
Hi. I'm Gavin Harris with the HHS Region 4 Special Pathogen SITREP. First to Nigeria, where Lassa fever is still present, though abating. In the most recent reported week that ended on the 15th of September, since the beginning of the year, there have been 8,251 suspect, 17 probable, and 1,005 confirmed cases, equating to a case fatality rate of 16.9%, slightly down from last year. Now to Crimean Congo hemorrhagic fever, where in September this year, there have been 3 confirmed cases in Iraq, India, and Pakistan. We are nearing the end of the expected peak season for CCHF, and we expect these numbers to be a dramatic undercount given the difficulty with surveillance in these countries. Outbreaks typically have a case fatality rate of up to 40%. Unfortunately, another fatal case of Nipah virus was confirmed in India in the state of Karnataka on the 9th of September. 5 of the 24-year-old's close contacts have been exhibiting symptoms and are currently under isolation. Once again, the prospects of human-to-human transmission have been raised. Lastly, to highly pathogenic avian influenza H5N1 or bird flu. In the United States, we have had now a total of 15 confirmed human cases since 2022, 4 following exposure to dairy cows, 10 following exposure to poultry, and 1 with no immediately known animal exposure. Additionally, as of last week, the CDC reported that a household contact and a healthcare worker who both had contact with the case without animal exposure have preliminarily tested positive. These human cases have occurred in Michigan in Region 5, Texas in Region 6, Missouri in Region 7, and Colorado in Region 8. The overall risk to the general public remains low, but as a reminder, people should avoid exposure to sick or dead animals, unpasteurized, or raw milk. Those who have occupation-related contact with birds should wear recommended personal protective equipment. We continue to monitor this situation both in humans and in bird and cattle populations throughout the country. Finally, there have been no reports of other suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu.
And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level with this topic. So the first question is, how knowledgeable do you feel about the current state of dengue fever in the Western Hemisphere? Choices are not at all knowledgeable, slightly knowledgeable, somewhat knowledgeable, very knowledgeable, or extremely knowledgeable. And then the second question is, how comfortable do you feel regarding the appropriate clinical management of a patient with suspected or confirmed dengue fever with the same choices based on comfort level? So if you can please answer the poll questions now. All right, and as you can see, we have a pretty wide distribution of our baseline knowledge of dengue fever, including a quarter of us who disclose that we're not at all, or don't feel not at all knowledgeable. And then in terms of the second question about comfort level of management, it looks like about 44% feel not at all comfortable. So looking forward to learning together. And with that, it's my pleasure to begin, and I will turn it over to Dr. Fairley for our didactic presentation.
Okay. Looks like my slides are up there okay, I presume. Yep, great. Well, thank you so much for having me here today. I'm really excited to be part of today's session on dengue virus. So I'm going to present actually two cases because I think they show um, both similarities as well as differences in both the clinical presentation and epidemiology. So I'll get right into it. So for our first case, we have a 35-year-old woman, very healthy, who presented to our clinic, Emory Travel Wells. Just as a preface, both of these cases were in the last 1 to 1.5 years. So pretty recent. So she came into the Emory Travel Clinic with rash, diarrhea, abdominal pain, and fever after a 1 week trip to Cote d'Ivoire. So about 6 days prior to presenting to us, she developed her first symptoms, which were headache. This was our last day in country. She flew home and at that time started developing more infectious symptoms. So fever to 102. She was seen in airport clinic en route and on her layover and had a negative rapid malaria test. Then the day after she arrived back, she was still feeling quite bad. She went to the emergency room, tested again for malaria, which was negative, and had some more additional testing, which we'll get to. She then started initially feeling better, but then 2 days before coming in, developed profuse diarrhea. Went back to the emergency room the day before, was treated with fluids, had some repeat labs, came into us, was feeling a bit better, still with the diarrhea. So now we're on day 6. She's complaining of 6 out of 10 abdominal pain and a new itchy red rash, which was over her entire body. So here is a little, not the best quality picture, but you can see a picture of her shin on the right. She had pretty normal vital signs at the time, was not febrile. In fact, she hadn't had a recurrent fever in the last couple days. Her vital signs were overall within normal limits. Of note, her abdominal exam was non-tender to palpation, at least no guarding, was overall soft, and her lungs and heart and exam were normal. So you can see this is just one part of her skin, but she had essentially over in her entire body a macular erythematous blanching rash on her legs, torso, and arms. You can see the fingerprints of the examiner there showing that it's a blanching rash. So I'm showing you her lab test that we're on. So remember, so emergency room visit was her first emergency room visit. So that was about 5 days prior to presentation, and then her repeat labs on the day of presentation. She initially had some leukopenia, which then resolved. Her hemoglobin went from 11.3 to 14.3. So when we talk about some of warning signs and some things to look out for. Remember that. Her platelets did drop to 145K. And at the time of her clinic visit, she had developed elevated transaminitis from about 54, slightly elevated to 222 and 217. She did have a little bit of hyponatremia, but her kidney function overall was fine. And again, she had malaria smears that were completely negative after the rapid test. And then here were her serology. So these, her initial dengue serologies were done at the time of her emergency room visit. So you can see she had a positive IgM. And then her IgG, just within 4 days, went from 1.94 to 13.62. Um, just a little bit more, since we always, at this time, we had some of her for her data back, but it's important to delve into a little bit more about travel history and what they were doing, and maybe other protective measures. So she was in the capital city the whole time, mostly working in the office. Interestingly, she forgot her yellow card, so had the yellow fever vaccine in the airport on arrival, and she did not take malaria prophylaxis on this trip. Um, so she was seen in clinic for close follow-up 2 days later. She have felt much better, and her labs had essentially normalized. So her hemoglobin, platelets, AST, ALT, trending down, and were normalized. So she did not require um, hospitalization, but had a very close follow-up with the clinic. So moving on, we'll go to our next case, which was a 40-year-old healthy man. So he came back. So now we're looking more in the Western Hemisphere after a trip to Argentina. While he was still in Buenos Aires, he developed fatigue and chills, and he was diagnosed clinically with dengue at a physician there. 2 days before coming in, he flew home, and then that's a kind of similar story. He developed high fever, shoulder, knee, elbow pain, kind of en route, headache behind the ears and eyes. One day before coming in, he had some minor epistaxis when blowing his nose. This happened about 30 times, and every time he blew his nose. And he continued to have body aches, pain behind his eyes, and a bitter taste in his mouth. Um, on presentation, he did feel a bit better again, but had developed some non-bloody diarrhea, and developed a rash on the left side of his chest that day. But he had noticed kind of this skin almost sunburn like redness on since the start of his illness. Additional history that he was in Argentina for quite a while. He was there for 5 weeks. His first week he spent up in high altitude areas in northern Argentina, came back to Buenos Aires, went down to Patagonia, But the last 3 weeks, he was in Buenos Aires during a bad dengue outbreak. He said there were swarms of mosquitoes, and he suffered lots of mosquito bites. He himself is from Latin America, but living in the US for 20 years. On the right, you can see his exam, again, non-toxic appearing, although it was a bit diaphoretic. Um, he did have some soft palate petechiae and a blanchable erythema diffusely. Again, also just to note, his abdominal exam was unremarkable. So here you can see the palatal petechiae, as well as a very stark handprint on his chest, so you can see the blanching erythema. His laboratory results, he was also a bit hyponatremic, as our first case also had some transaminitis that peaked and then came down, um, was leukopenic at initial testing. Um, he had a baseline high hemoglobin, about 15.6 was his baseline, but he did go up there, and was a bit thrombocytopenic when he first came in. He also had a positive IgM on the second, kind of was indeterminate on first check and then became positive, and also had a high IgG on both checks. He was also managed as an outpatient, was followed very closely, and had it kind of was healthy at baseline, and given strict instructions on what to look for. And his labs worsened then improved. I know that we are going to go into more of the clinical presentation with our next speaker, so I will do this quickly, but you can see from the clinical presentation that they really had many of the typical symptoms, rash, which is only seen in about half the cases, some minor bleeding in our second case, um, and this kind of typical break bone, lots of arthralgias and headaches, retroorbital pain. But a lot of infections are asymptomatic. We also saw a bit of this biphasic illness, both with the febrile and just kind of feeling better, then feeling worse again. They had very typical laboratory findings, and fortunately, neither of them went on to a critical phase, but you could tell that at the time of their presentation, especially with the abdominal pain, that they were kind of borderline whether they could, move on to severe dengue or not. Um, Severe dengue is marked by more of like the plasma leakage, pleural effusions, hemoconcentration, which we actually did see in both cases, fortunately resolved quickly, and then the convalescent phase, and then there's been more and more kind of recognition of prolonged symptoms, kind of like long COVID, fatigue, brain fog, and other symptoms. Um, I will move quickly from this, but some of the warning signs that we look for in the clinic, definitely abdominal pain, especially with palpitation and it's continuous, persistent vomiting, any evidence of fluid in the lungs or anywhere else. For sure, altered mental status, and then some of these serious lab signs like coagulopathy, severe organ impairment, high significant hepatitis, and myocarditis. Um, yes, so since we will be reviewing this in the next one, I will move on. And that's it. Thank you.
Thanks, Dr. Fairley, for the excellent case presentation. For the didactic portion, I'm going to hand it over to our guest, Dr. Sanchez Gonzalez.
Thank you, Dr. Baki. And let me see if I can do this. This was the hardest part of the presentation so far, to be able to share with you. Let's see. Okay, can you? Perfect. So thank you very much again for the invitation. It's great to be back. And good morning, everyone. In this very short 15 minutes that I have, I intend to give you some reasons why you should care about dengue, and I'll give you a brief epidemiological update and some key concepts of clinical presentation and management. So I have to start with the disclaimer that these are my own findings and conclusions. And let's dive right into the EPI update. So you might have seen dengue in the news lately. These are recent, all of them recent headlines. 2024 is the year with the highest number of dengue cases on record, and already surpassed 2023, which had been the worst ever reported. Multiple countries reported the biggest outbreak ever this year, and there is an increased concern on the public health impact of dengue around the world, given the global surge in the number of cases, the geographical expansion of the disease, and the potential that dengue has to overwhelm health and hospital systems during outbreaks. This year, more than 12 million cases have been reported from more than 100 countries across all regions in the world. And because of the increase of the dengue cases since last year, the WHO declared a multi-country grade 3 outbreak and an emergency response that is still ongoing and require an important response from the agency. This is a map from the WHO Global Dashboard that is showing the total number of cases by country that were reported to them. The darker color is showing the higher number of cases. And as we have better surveillance systems and more way to confirm the diagnosis, more laboratory capacity, we're able to see a better picture of what is really happening with dengue and seeing it in places where we had not identified before. In this map, I want to highlight that several countries in Africa have identified an important number of dengue cases this year, and dengue has been increasingly recognized as a cause of viral illness in this region. Some European countries also report locally acquired dengue cases seasonally because they do have the dengue vector established in some areas. But the majority of cases are concentrated in the Southeast Asia region and in the Americas region that accounts for most of cases where we are. And this is a graph that is showing the number of cases reported per year since 1980 in the Americas. As you can see, 2023 had been the worst year on record with 4.5 million cases reported. That was a big increase. But then this year we have more than 11.6 million cases reported. This includes all suspected, probable, and confirmed cases. More than half of these cases, more than 6 million cases have been confirmed. And we have had a report of more than 6,600 deaths associated with dengue. And although at this point of the year, the cases in the region as a whole are in a downward trend, there are still several countries that are reporting higher than usual number of dengue cases. We should be aware of them. So I want to show you this map that contains the most recent travel health notices for dengue. These are updated monthly by the CDC, and it is a good resource for travelers and clinicians. So I wanted to make sure that you are aware of it. As you can see, several countries in the Americas region are reporting higher than usual number of dengue cases. As a reminder, CDC does not recommend suspending travel to countries with increased number of dengue cases, but rather we recommend that travelers practice mosquito bite prevention measures throughout their travel time. In the United States, most dengue cases are travel associated. This year, we have had so far 1,750 cases reported among travelers from 50 US jurisdictions, compared to, I put the number there for you, 1,890. This is the highest number that had ever reported last year in 2023. So we still have 3 months into the year, and we are very close to what we see last year with our record year. So it's probable that this will become now our new record year for dengue in travelers. And I included here the 5 states with the highest number of travel-associated cases. You can see Florida, New York, and California are at the top of the list with the most number of cases. So remember, if you are in the continental US, the most probable case scenario for seeing a patient with dengue, as we saw with our first 2 dengue cases presented, it is in a return traveler from an dengue endemic area or a place with a dengue outbreak. Dengue is also endemic in 6 territories and freely associated states, and Puerto Rico declared a public health emergency due to a dengue outbreak earlier this year in March. CDC activated a dengue emergency response back in April. It is still ongoing, and we are supporting the Department of Health with all the work that they are doing to control this outbreak. I don't know why you can see that. You're supposed not to. Oh my gosh. Let me just do this. Sorry about that. With all the work that the Department of Health is doing during this outbreak response. We have had more than 3,300 cases, and about 6% of the cases in Puerto Rico have been reported as severe dengue cases. The type that is predominant in this outbreak is dengue 3 that had not circulated in the island for a little bit, but has been associated with different outbreaks around the world in recent months and years. And we have had so far 5 dengue deaths, of deaths associated to dengue in the island. And so the global increase in the dengue cases that I mentioned at the beginning, the increase in travel-associated cases in the US that we have seen in the last few years, and this Puerto Rico epidemic are some of the reasons why our CDC issued a health advisory back in June. One of the objectives of that health advisory, as it is with my presentation today, is to increase suspicion of dengue among clinicians who are seeing patients with fever who have been exposed to areas of dengue transmission. And lastly, because we have areas in the US with the presence of the mosquito vectors, the Aedes mosquitoes, we have some areas with local transmission. Sporadic cases and some limited outbreaks have been reported in Florida, in Hawaii, and in Texas. And more recently, the first evidence of local transmission has been reported and confirmed in Arizona and California. This year, we have 35 locally acquired dengue cases reported in Florida. And very recently, you might have seen this in the news recently, 3 dengue cases in California. And so here I want to remind you that the most likely scenario is dengue among a traveler, but also it's important that dengue transmission risk is considered by all health professionals in all the areas of the US where local transmission has been identified in the past and where we do have the mosquito vectors and local transmission is possible. Now, quickly, Dr. Fairley mentioned some of these, so I just want to emphasize 2 aspects of the disease that we should all assess in every patient for which we suspect dengue, and so I'll try to go quickly. First, very important to classify the severity of the disease. We use the dengue clinical classification from the WHO that divides or classifies patients in dengue with warning signs, and severe dengue. We use this classification for treatment, so it's important that when you are facing a patient with suspected dengue, you use this classification. And so all patients with fever and the right exposure to an area of dengue transmission who present with any of the criteria listed there that we discussed previously meet the dengue definition. Symptoms, as Dr. Fairley mentioned, can be very incapacitating and can include important gastrointestinal and sometimes respiratory symptoms, and patients can still have dengue. So those don't negate the potential dengue diagnosis in a patient, as we clearly saw in our 2 cases. Remember to look for warning signs. These are warning signs for the progression to severe disease, and we need to look and assess those in all the patients for which we suspect dengue. I even put a red line around so that you remember. And I want to draw your attention to the last one. Please note that platelet count is not a warning sign, but hemoconcentration is. We care about the platelet count, but it's not the main, it's not the where we should put our main attention for dengue patients. And severe dengue criteria that were already mentioned too. I just want to mention that the main manifestation or the most common manifestation of severe dengue is shock. We hear a lot about dengue hemorrhagic fever, but the most common complication and the most common reason why patients with dengue die is shock. So we should look for early signs of shock in every patient with suspected dengue. And then the other aspect of the disease, you look at the severity and you also look at where is the patient in the clinical course of the disease or in which phase of the disease the patient is. And so after the incubation period, in patients who present with symptoms, the typical clinical course of dengue has three phases: the febrile phase, the critical phase, and the convalescent phase. And so during the febrile phase, this is where we see all the common symptoms of dengue that we already mentioned. And then after 2 to 7 days of fever, that is a common duration of fever, as the temperature goes down or disappear, most patients will recover, as with the two cases that we saw, but some patients can enter into the critical phase. This is where an increase in capillary permeability happens, and it is where extravasation of fluid into the third space or plasma leakage usually happens. So in dengue, we need to pay special attention to those 1 to 2 days after the fever goes down to make sure that we identify warning signs and that we identify early signs of shock, and that we recommend patients to return to the hospital if they are not already there. And then in the convalescent phase, the extravascular fluid that leak in the critical phase needs to be reabsorbed. This is when the patient starts to improve. And then here is where we typically see, Dr. Farley showed very nice pictures of the febrile rashes, and I'll show you a picture of the convalescent rash of dengue that is the typical rash of this phase, and that we call commonly islands of white in a sea of red, and that can be very pruritic, and you can see in some of your patients in this recovery phase. Now for dengue clinical management, I don't have time to go through a lot of details, but I want to give you some important messages for clinical management to have in mind when you are facing a patient with potential or with suspected dengue. If you suspect dengue, manage and monitor your patient as dengue. Do not wait for lab confirmation. We do not need to wait for lab confirmation. But I want to mention here that if you are in the US, we ask that you order confirmatory testing if possible, PCR or NS1. These are molecular testing tests, and they are available in many parts of the United States. And if you need help with deciding which test to order or with testing overall, dengue is a notifiable disease in the US, so you should contact your local health department, and they can also help you figure out testing if needed. Sometimes IgM is negative in the first days of the disease, so it's important to try to confirm dengue cases for public health and epidemiological purposes. For clinical management, you don't need to wait for that. All patients can progress to severe disease independent of the infected serotype, the age of the patient, the number of the infection. All patients can progress to severe disease, and we should all monitor them as with that potential to progression to severe disease. And then based on the clinical presentation, the severity of the things we already saw, the phase of the disease, the comorbidities, and other conditions like pregnancy, for example, we classify our patients in 3 groups. Group A, patients who can go home. Group B, patients who need to be under observation. And Group C, patients who need a higher level of care because of the severe disease. Most patients will be under Group A, and they can be managed at home, like the patients presented today. And usually it's just bed rest, oral hydration, very important, especially in children. It has been associated with a decrease in the need for hospitalization among children. Very important to emphasize oral hydration in all patients who can drink, and then fever management and symptom management. Pregnant patients should be hospitalized. There is a current recommendation for pregnancy. And then I want to remind you that there are no antivirals or specific medications available for dengue. The management is supportive and mainly with IV fluid therapy. Here is the dengue case management pocket guide that Dr. Fairley also presented. And I think the link got in the wrong page, but there is a link where you can go print the pocket guide. It has all the recommendations from the current guideline, but also you can order printed copies if you are in the US and you want some of those. We always obtain a reference hematocrit before we start IV fluid therapy. It is very important to have that. It can help you make clinical decisions along the way. And remember that during the febrile phase, we usually do not need to give the patient IV fluids. If the patient can drink, encourage oral hydration, even if the patient is in the hospital. Many times we don't give IV fluids until the patient enters the critical phase and really needs the IV fluid therapy. We usually only need them for 1 to 2 days, the duration of the critical phase where the plasma leakage occurs, and then we can just suspend them based on the clinical progression of the patient. Because we only need, to give them the minimum IV fluids amount that it's necessary to restore IV volume to maintain good perfusion, for the patient to be stable, have a hemodynamic stable status, and correct urine output. And so one key message that I want to mention here too is that IV fluids are increased and decreased in a stepwise manner. Again, I won't go through the details, but this is how it looks in the pocket guide. We guide you to assessing the clinical presentation of the patient and based on that, decrease or increase the fluids to try to get the patient to that stable status without overloading the patient. And so because that is how we manage dengue patient, the monitoring and the reassessing of dengue patients is very important. And it's one of the reasons why during outbreaks it is so hard and health systems and hospitals are overwhelmed. This requires a lot of resources, human resources, to monitor and reassess and change the orders or the clinical conduct with these patients. We need to remember to look for early signs of shock in all patients. Remember, this is the most common complication for dengue patients, and you don't need to wait until there is hypotension or frank shock to increase or start the IV fluids. This is especially important in children. Remember, not bleeding is not the most common severe dengue manifestation, it's shock. And patients with severe dengue should be ideally placed in an intensive care unit. We do not give steroids routinely in dengue patients. There are some specific recommendations for them, but it's not a recommended routine treatment right now. And we do not give prophylactic platelets transfusions. It has not proven to be beneficial for dengue patients, and it can overload the patient with fluids, and we do not recommend them routinely either. And so besides the increase in the number of cases, the potential that you have to encounter patients with dengue in the US, I want to remind you that the unrecognized disease is a common cause of death, sadly, even in endemic areas. And this is one of the reasons why you should care about dengue too, because recognizing the disease early and giving the patient the appropriate clinical management with IV fluids can be life-saving. So we are expecting to see more dengue patients, but we can also have the potential to use adequate clinical management to decrease morbidity and mortality in dengue patients. It's the only measure that has proven to be effective in decreasing mortality among dengue patients, and we have the chance to do that with adequate clinical management. And I want to finish with some contact information. If you have any question, any concern about your patients, if you have questions regarding clinical management, even testing, we're always very happy to hear from you and to work with you. And we work very closely with the local departments of health, of course, and to try to help you with any patient for which you suspect dengue or you have dengue and need help with clinical management. Well, I'll finish there. That's what I had for you today. Thank you.
Thank you, Dr. Fairley and Dr. Sanchez-Gonzalez, for your excellent presentations. We'll now open the forum for Q&A. Reminder, if you have a question, please type it in the Q&A section, and we'll attempt to get to all questions. I can see a couple that have come through that I thought were interesting enough that I wanted to kind of bring to the whole group. Maybe we'll start there. We'll start in this first one. I might direct to Dr. Sanchez-Gonzalez, which is timely for those of us in the Southeast. Do we think that the current storm Helene could cause more cases in Puerto Rico?
I might be wrong, but I don't think we are being affected by Helene in Puerto Rico. So I can tell you that what we've seen during storms is that at the beginning, there is a little bit of a washout of the mosquitoes. And so we see that there is a decrease in the amount of mosquitoes. So hopefully a decrease in the transmission, but then they come back right after because there are more potential breeding sites for them, water, flooding, all of that. But I'm not sure that we are going to be affected by this storm.
Great. No, thanks. Thank you for that. This next question I may direct to Dr. Drenzik, and it's an interesting one. I don't, as an ID physician, I don't know the answer to it. The question is, what is the current policy regarding screening the blood supply, or I guess blood bank policy for screening the blood supply in countries with high rates of dengue infection?
Thanks, Jay. Yeah, I know that here, certainly in the US, it is not routinely screened for. I can't imagine that it would be a routine screen in any case. And I think that considering the clinical presentation, I think that when we're looking at blood based screening, although certainly there are some dengue infections and many that may be asymptomatic, considering the recognition of such a potential for severe clinical, I think it's probably not, sort of a priority um, uh, screen as far as, with whatever resources and tests are needed for that. But I know it's not done here. So.
Yep. No, thanks, Dr. Drenzik. Anything you would add, Dr. Sanchez Gonzalez?
Yes, no, I'm also not aware of anywhere where there is a policy in place to test for all the blood supply for dengue, even in endemic areas.
Great. Thank you. This another question is, and you mentioned some of the sources, but are there main or consensus guidelines for the clinical management of managing patients with dengue hemorrhagic fever, especially regarding fluid control and monitoring for complications? And are there any specific recommendations to prevent progression to more severe forms of disease? Dr. Sanchez-Gonzalez, you emphasized kind of the role of supportive care and IV fluids. Did you want to touch on this question?
Yes, absolutely. So we work very close with WHO and PAHO, and our recommendations are based on their current recommendations too. And the last WHO guideline, I think, is the one in 2009, but it's been revised this year. So they're hoping to have something very soon with additional recommendations. But those are the main principles, just to give enough fluids to keep the patient stable, to not overload the patient, but then avoid progression to shock as soon as possible. Other than fluid management, there isn't really a lot of other recommendations available at this time. Recognizing warning signs is very important. They have been associated to progression to severe disease, and we know that if we address plasma leakage earlier in the disease, we have the potential to decrease that chance to progress to severe disease.
Great. Thank you. This next question is a good one. It's, I think, one of the core ones that I may direct it to Dr. Fairley, wearing her hat in the Emory Travel Well Clinic. So the question is in the theme of prevention. So the question is, the best management is really to avoid the mosquito bite, correct?
Yes, of course, that's I would be out of a job if that wasn't the best way to prevent. But yes, it is the best way. However, as most, all of us that live in Atlanta, I know a lot of you don't, but live in places with a lot of mosquitoes or travel to, and that even bug spray and repellents are not perfect. And this second case, it was enough. It was a He said that the mosquitoes were just everywhere. So it is interesting. Sometimes we see people and ask about mosquito bites, and they said, no, I don't think I got one, even though they had malaria. But then there's, some obvious where like it just was just so difficult to avoid getting the mosquito bites. So we can do our best, and there's lots of different ways to prevent mosquito bites through um, DEET, through permethrin on your clothes, through the mosquitoes that spread dengue are daytime mosquitoes. So, but for at nighttime, pathogens, screens and bed nets and all that. So.
Great. Thank you. This next question, sticking with the theme of prevention, I may direct to Dr. Drenzik, just given we usually the participants have a heavy infection prevention and hospital epi and public health background. So the question is, what personal protective equipment beyond standard precautions are appropriate for healthcare personnel to wear for the initial assessment of patients with suspected dengue?
I am not aware that there are specific recommendations for, additional PPE. We wouldn't really consider the presentation of dengue to result in this kind of person-to-person transmission in a healthcare setting. So,
Right.
Yeah.
Thank you. The sixth question I may direct to Dr. Sanchez Gonzalez. Is there research regarding types of oral fluid management and the impact on progression to severe disease?
Yeah, I don't think there is a lot of research on the specific type of oral fluids. There are a couple of studies that have shown that increasing that amount of oral fluids, and we do have the list of the recommended oral fluids, that you can use for dengue patients, not just water, but juices, soups, milk, all the different things that you can use. It's more about the amount of oral fluids that you give, especially to children. And the difference in outcomes for hospitalization has been demonstrated that if you start that early and kind of make the child to drink a lot of abundant oral fluids, it's possible that they don't progress to severe disease.
Great, thank you. This next question, I know Dr. Fraley mentioned post-infectious sequelae of many infections, including dengue. This is an interesting one. I invite any of the panelists to answer, this is a personal description. I took care of a young female with dengue admitted for severe diarrhea and myalgias who developed alopecia 4 to 6 weeks after hospital discharge. Do we know how frequent we see this sequelae and any experience to managing it?
Well, I would probably defer to Dr. Sanchez Gonzalez, but I have kept up on a little bit of just, the literature that a lot of, I think there's more kind of brain fog, fatigue, kind of the neurologic sequelae of dengue, but I'd be interested to see what else is out there.
Yes, that's very interesting. There is a recent paper that was published. I think it's in emerging infectious diseases. They follow up a cohort of patients with dengue, and they identified alopecia as one of the long-term symptoms. So I can't remember the proportion of patients that presented alopecia, but it was definitely identified and higher in patients with dengue in those with other viral illnesses. I can find the link for you and we can send it to the attendees. But yes, it has been described, and as Dr. Fairley said, but it's mainly about concentration issues, brain fog, some mental health issues, depression, anxiety have been also associated long-term as sequela for dengue. And there is a lot of interest in learning more about what's happening with dengue patients in the long term, because there are a lot of things that we definitely don't know yet.
Great, thank you. Next question is, I may have missed it from the beginning, but is there a season for dengue? And so that's question one. Question two is, are the disease-carrying mosquitoes more active at certain months, seasons, weather in the US and other countries? Dr. Sanchez, you want to take this one?
Yes, there is definitely a seasonality component of dengue in all endemic areas, and it has to do a lot of, I think, related with the first question of after the hurricane or storm, what happens. And with the rain, then mosquitoes have more potential breeding sites, and we see a very nice pattern on it rains and 2 weeks after we have a lot of mosquitoes. It rains and 2 weeks after we have a lot of mosquitoes. So definitely there is a seasonal component. Any change by region and country, right? The season in Puerto Rico is different than the season in Argentina or in Mexico. So it's important to have that in mind when you're assessing risk, because definitely it's not the same time pattern and it's not the same seasonality. But yes, we see the peaks of the cases in specific seasons, mostly related with rain.
Great. Thank you. Um, Dr. Sanchez-Gonzalez, I'm going to direct this next question to you too. And again, I want to highlight, because you made this point very clear in your presentation, that there has to be a high clinical suspicion for dengue, and that their clinicians should not wait in terms of confirmatory diagnostic testing to start supportive care, provide supportive care. But one of the questions is, could you comment on the laboratory tests for dengue? You mentioned PCR, you mentioned serology, but the other question is there any data to show a correlation between lab values and severity of disease?
Oh, interesting. I'm not completely sure that probably has been done, but I'm not completely sure that is something that we have widely available anywhere to see, if the vital loads or other parts of testing it's related to the severity of disease. It is important to try to confirm the diagnosis. PCR and NS1 are usually are usually positive in the first 7 days. We usually see patients during the first 7 days of disease. So we emphasize that if you have the opportunity to do testing, that you include confirmatory testing if possible. We are seeing more and more that PCR and S1 are being positive longer in the disease period. So, you can always check with your local health department and see if testing after, how to test after 7 days, for example. But I'm not completely sure about the specific correlation between viral loads and severity.
Yeah, great. Thank you. This next question, I think, is also in the theme of concerns about climate change and the changing epidemiology of infectious diseases. It's a conceptual question. I'd invite all the panelists to answer. Maybe I'll start with Dr. Drenzik, go to Dr. Sanchez-Gonzalez, and see if Dr. Fraley has anything to answer. But the question is, how are we, and I think we, it means the public, quantifying the effect of human-caused climate change as a cause of surge in dengue cases? But I think this probably applies to a lot of different infectious diseases.
Yeah, I would agree, certainly, and I think that as we look across the board, again, as Dr. Sanchez Gonzalez illustrated, not only are we seeing, recently, these huge, kind of record number of cases of dengue in both endemic and non-endemic areas. I think when we're talking about quantification, I think it's just at what level, and we are seeing much of this across the board. So is it just case numbers alone? Are these things underreported? Certainly, there's that component, but as far as like quantification, I'm not aware of something very specific in regards to for example here in the southeastern United States as an example, but we can attest by surveillance, at least for these infectious diseases, so the ones that are notifiable, that we have seen a great increase, and also over the last 10 years in my job, a great increase in the number of travel associated infections as well. So
Great, thanks.
Yeah, thank you.
Yeah. Dr. Sanchez-Gonzalez, Dr. Farley, anything else you would add?
Yeah, I mean, I have this really strong interest in climate change and infectious diseases. So, I mean, there's lots of, dengue is probably the best described pathogen with climate change, meaning there's been a lot of studies on looking at the vector, modeling out different scenarios, looking at dengue epidemiology after disasters and storms. So obviously we know that it gets worse with weather, more extreme weather. Um, how how the I think what this question is getting at though is like how do we prepare, and have do this more systematically, moving forward. And I think that's a really good question. I think as a clinician, the biggest thing for me and maybe how my thinking has evolved is that the rules of epidemiology don't necessarily apply. If someone comes in and they went to a place that doesn't supposedly have a vector-borne disease, I used to like not test for that disease, but now I wouldn't. I think you have to have an open mind and understand that, things get introduced, that epidemiology could change, that things are underreported, underrecognized, and really anything's possible, now with climate change, unfortunately. So I've really looked at this as, this is our opportunity, to really start describing these associations, start more and more, and think about these diseases even in areas that we might not have previously.
Oh, no, I thank you so much for the excellent discussion and the answers to the questions. I did promise Yasmin and Dr. Harris that while standing in that I was going to try and keep timekeeper, and I'm looking at this. I'm going to have to wrap up our discussion and call it to a close. Do want to thank each of our panelists and the audience. But before we close, I do want to again just pose an interactive question for the audience after participating. Question is, how comfortable do you feel now about the current approaches to preparedness and clinical care of patients with suspected or confirmed dengue virus? Not at all comfortable, slightly comfortable, somewhat comfortable, very comfortable, or extremely comfortable. Okay. And at least from some of the initial questions, it looks like all of us have a higher comfort level, and that's excellent. Although no one's feeling extremely comfortable, but that's fine. This is with this field, we all learn together. Great. Thank you so much. But do want to thank everyone for participating in today's session. Thanks again to our technical team here at SCDP Echo, specifically Yasmin Thornton, our Project Echo coordinator and leader extraordinaire, our planning committee with Sharon Van Arsdale, Anish Mehta, and Allison Claybore. In terms of just a reminder to please access the resources and subscribe to the podcast. For feedback and further information, including continuing education credits and the recording, please check the links here and at our website. Our next session will be held in 4 weeks, and we look forward to seeing you again soon. Thank you.